Hi, everyone, and welcome back to another Privacy International podcast from our Reproductive Rights and Privacy Project. I am Sarah Nelson, and I lead the Reproductive Rights Project here at PI. Today I'm speaking with Tasneem Mewa and Ambika Tandon, both of which work with the Center for Internet and Society in India. I am speaking with them today about research they did with PI about data exploitation in sexual and reproductive rights in India. I asked them to describe the landscape of reproductive rights in India, specifically related to the ability to access contraception, the ability to access abortion care, and also the accessibility of medically accurate sexual health information. We also talked about foreign organizations that work in the country to develop different technologies to provide information about health and information about different reproductive services. So I hope you enjoy this conversation with Tasneem and Ambika. So I guess to begin, could you maybe give an overview of reproductive rights in India, specifically related to access to contraceptives, abortion care, and medically accurate sexual health information?
Okay, so I'll start with this question. In terms of reproductive rights from a legal perspective, there is the Mtp Act, which was initially drafted in 1971 and has had several amendments since then. And within the Act, women have the right to reproductive autonomy over their body in terms of the choice that they make, and they are given that right to have that autonomy as well as the right to privacy, and that right to privacy has been emphasized since the 2017 judgment. And so from a legal perspective, nationally, women are given the right to choose what reproductive healthcare services they would undergo. And in terms of abortion, there are definitely restrictions on abortion and when they can seek it, in terms of at what gestational period they can seek out abortions. And so there are restrictions in terms of that, but women are allowed to seek out contraception, seek out abortions from a legal national perspective. And that often doesn't translate into reality, one, because the national government kind of delegates the enforcement to state governments. And so state governments have their own kind of rules and approval processes for public and private facilities in terms of what constitutes a safe and legal abortion. And in addition, there are also kind of different rules around contraception. And if we look at Chennai, for example, and Tamil Nadu, in 2005, when the state government decided, the national government and then the state government decided to make contraceptive pills available for people in Tamil Nadu, there were groups who kind of rallied against that and lobbied against that, saying that those pills induced abortion, even though they didn't. And because of that, the state kind of redacted that bill and didn't allow those contraceptive pills to be sold anymore. And so there's a lot of variation between states. And so the legality of abortion, of contraception, and of the right of the woman to choose doesn't necessarily translate. And there's a lot of misinformation around the legality of that and a lack of awareness among people who are supposed to be providing these services.
I'll quickly add to what Tasneem was saying. So with the Medical Termination of Pregnancy Act 1971, that like Tasneem mentioned, there have been a few amendments, and the original act was more limiting than the more recent amendments have sort of allowed more space and more autonomy to women. So, for example, one of the provisions that have been amended is that you can now seek abortion up to 24 weeks instead of the earlier 20 weeks. And the issue, though, is that still requires the approval of 2 medical practitioners, and up to 12 weeks the approval of 1 medical practitioner. That's lower than the 2 which was required earlier, but it still places bodily autonomy in the hands of the medical practitioner. So you still have to um, gather approval, and like Tasneem was saying, there are enforcement issues because of that, because it's not a right that you can sort of demand abortions as such. You have to um, the provision of seeking approval means that there can be um, ad hoc requirements that come up locally at given different medical practitioners. Um, and the other amendment that I wanted to highlight was that earlier the provision of seeking abortions for forced for sorry for the failure of contraception was only limited to married women, and now that has been sort of broadened and includes uh, all women within that scope. So that's those are some positives from recent amendments, as recent as March 2020. Uh, but there do continue to be issues around bodily autonomy.
Anyone who is under the age of 18 has to seek consent before they choose to undergo any of these procedures or any of these services, and that also creates more stigma for young unmarried women, especially if they undergo consensual sex, because anyone under the age of 18 is considered a minor, and so if they did go to a public facility, it would be reported to the police, I believe, and so that also creates a sort of criminalization along with illegalization of or like a sense of illegalization around anyone under 18 who is seeking these services.
Is that for both abortion and access to contraceptives?
I think that's
Yes.
just that's
for contraceptives, in the sense that you are so any sex that you're having while under 18 is considered illegal. So if you while there's no law around accessing contraceptives, so you could have access, but there is no right to have access to contraceptives as a minor. And as an abortion seeker, you are in all probability, in all likelihood, will be approaching a private provider, because if you do approach a public medical provider, then you will have to go through a legal procedure. It will become a medical legal case.
So in the case of an under 18 person seeking contraceptives, there would be police involvement with that then?
Yes. Yeah. So I was interviewing women and providers in across major hospitals in Delhi, government hospitals. And one of the issues that came up around consent was that the providers were hesitant to provide to go ahead and give approval for abortions for anyone that they thought was it was so unmarried women are going through multiple screening levels, and so one of the criteria that they had to screen women was if they thought they looked literate or had an understanding of what they were talking about. So and this provision and this criteria was being applied regardless of the age of the woman. So I had approached and asked about unmarried women who were, say, around 25, 26. So they said that if it's someone like you who looks like they know what they're talking about, then we would go ahead and take that risk. And this was the terminology that was used. So there's a sense of risk around giving approval to unmarried women who are seeking abortions, and they wouldn't do that if it was the case that if the woman seemed like she was either illiterate or was not able to explain very well what the circumstances around her abortion were, then they would involve the police and it would become a medical legal case again.
Could you talk about how sort of different forms of data exploitative tech are being developed to delay or curtail access to reproductive health services, including access to contraception and access to abortion care?
In terms of data exploitative technology, I think in general with technology, we came to kind of two conclusions, which is that the integration of data exploitative technology within reproductive healthcare demonstrates that the provision and restriction of reproductive healthcare services are not mutually exclusive, especially in the case of data-based technologies. And because there are a variety of data-based technologies and a variety of ways in which data is collected from women within the healthcare system, all these private, public, and even non-governmental actors who are responsible for collecting this data in exchange for promoting sort of women's autonomy and women's empowerment are kind of pursuing those objectives through very narrow lenses and through ways in which that are kind of averse to a majority of the population, especially women who are from rural areas or women who are highly stigmatized for seeking out these services. And another kind of conclusion that we came to is that the policy around data exploitative technologies, or the lack thereof actually, is also contributes to kind of exacerbating the existing inequities and creating new inequities for a lot of women who are seeking out these services. So some of the examples that our research talks about are the different databases that have been created for provision via Aadhaar. And so there was initially the MCTS, which is the Mother Child Tracking System, which was implemented nationally in 2011, I believe. And that has slowly been linked to the national Aadhaar system, so that anytime a woman does try to seek out this service or is trying to access maternal benefits, for example, has to provide her Aadhaar number and her Aadhaar card when going to a public facility, and the data that is linked to her Aadhaar the data that is required for her to seek out the service is then linked to her Aadhaar and then centralized. And because there is really no data protection policies and data privacy policies in place for that data specifically, it is very vulnerable to the system and those who have access to it. And because there have been instances of data leaks, women are made vulnerable to the fact that their data could be leaked, and this is especially dangerous for women who would be stigmatized for seeking out these services, for young women, unmarried women, and people who would be stigmatized for seeking out the service. And then there's also the integration of ICT and apps such as Dr. Insta and Practo, and even apps that are, or SMS-based services that are kind of implemented by not only domestic actors but also international actors and designed by international actors, because a lot of these data exploitative technologies are seen as something that works well with development narratives as well, international development narratives, as well as how India wants to see reproductive healthcare go within a digital India kind of landscape. And so when women, or when anyone kind of tries to seek out healthcare services from these apps or from these M-based or E-based initiatives, mobile-based and internet-based initiatives, then sometimes that requires, again, them to input data and input information about themselves that isn't necessarily protected. And especially when these kind of spaces are advertised as safe spaces or places where women can seek out services that would normally be considered taboo or that they wouldn't be able to access otherwise, that creates a really kind of unsafe space for a lot of women and creates a notion of safety that is that isn't necessarily true. And then in terms of going back to the MCTS and the Aadhaar and the databases that are being created, a lot of these databases will, or eventually the government wants to see them kind of inform AI and AI being artificial intelligence within reproductive healthcare. And with the AI services, they want these databases to kind of inform what the AI services do, obviously, because AI needs a lot of data to work. And a lot of the data that is being fed into these AI systems is primarily based around pregnancy and fertility data, and doesn't really include a wide range of services that people seek out, especially because a lot of people who do seek out these services don't necessarily want it to be reported on their Aadhaar. So they go to private facilities, or they go to facilities that wouldn't ask for that. And so a lot of the data around the number of abortions that are being performed doesn't exist, one. And two, the data that does exist around pregnancy and fertility for these AI systems is extremely quantified and medicalized and created under this biomedicalization, biotechnology kind of lens. And so the event of pregnancy itself is quantified, for example. So the AI system would see it as pregnancy being this number of visits, or this number of postnatal immunizations for the child, or this number of whatever kind of metric that is supposed to define pregnancy. So not only does it really narrow the definition of what reproductive health is, but it also quantifies it in a really formulaic and inapplicable way for a lot of women. Mm-hmm. And so the way that these data exploitative technologies are working, while they're trying to, create accessible reproductive health care services for women across, across a lot of different geographical areas, it's not necessarily doing that, and in fact is actually creating an unsafe space, and allowing a kind of feeding data into an infrastructure that isn't necessarily built to protect and hold that much data, and is also through data kind of redefining and narrowing what reproductive healthcare and reproductive healthcare services really mean.
Really interesting.
So I'll chip in there as well, and just highlight some issues in addition to what Tasneem spoke about with regards to so the first is with the narrowing down of the definition of reproductive health. This has been an issue that has been pervasive within the development sector and the governance of reproductive health more broadly as well. And they really come out when these systems are then being datafied, and there is a very sort of narrow lens through which reproductive healthcare is being defined. So there are areas such as gender-based violence, for example, that have been seen as more contentious and are therefore not included in the space of reproductive health, even though they do have a direct impact on these. And the other issue, in addition to privacy, is that there are targets that are set for a lot of these metrics or indicators. So institutional deliveries is there is a target-based approach around that. There's a target-based approach around sterilization and basically bringing in both men and women to sterilize across rural parts of the country more starkly. And these when these targets are not being met, these are essentially monitored through the data systems that have been set up in place. And so the issue there is that these are not optimized to bring more autonomy to women or to broaden the service base for women, but rather to meet the or monitor the targets that have been set up in a top-down manner by governments and international donors. So with sterilization, this was an example that I have is from Madhya Pradesh just last month, where the chief minister had announced that health providers would lose their jobs if they are not able to bring in a certain amount of men to be sterilized by the end of the reporting period, which was in March. And there was so much backlash around this that this notification had to be retracted. But it is something that continues to happen in the health system across the country.
Most people that I think will listen to this and watch it will have an understanding of what Aadhaar is and the mother-child tracking system that you mentioned, but could you maybe briefly describe those systems and how the two interact, and if there are other initiatives related to reproductive health that feed into Aadhaar as well, and just kind of expand more on the potential risks that come with that centralization of information.
So the Aadhaar is India's biometric identification program. It was launched in 2009 and since then has been integrated across government services and welfare. And as part of that, the first link to reproductive health and the Aadhaar is that the sort of provision to or the law that is regulating sex selective abortion takes the approach of regulating technologies that are able to cater to sex selective abortion, so ultrasound technology essentially. And the regulation happens in a manner that providers have to register themselves with the government, and they have to procure a license. And after that, they have to take identification of some kind when women are coming in for ultrasounds. And this is both private and public providers. So at that stage, they demand identification, and there has been a sort of an ad hoc or an informal approach where providers are sort of leaning towards asking for the Aadhaar, and if the patient does not have an Aadhaar, then they may not necessarily ask for other identification. So there could be exclusion at that stage itself. And the second major link is due to maternity benefits. So all benefits across the board, including a number of state and central maternity benefits, are linked with the Aadhaar, and you have to authenticate yourself, you have to authenticate your identity if you want to avail of these. You also have to have a bank account which is seeded with the Aadhaar, which will receive these payments in case of a direct benefit transfer, which is the case with most paternity benefits. So you could then, the exclusions could then be happening at two levels. You could either not receive a services at all, which has been the case in a few documented cases across the country, or you could not receive your benefits. You could not be eligible for receiving a benefit, which you would otherwise have received if you had an Aadhaar. So that's the exclusion is the first step. And then if you do get included within these programs, then the centralization of information is the other issue. And the mother and child tracking system, which is which basically tracks maternal health indicators, maternal and child health indicators in India. It's a monitoring system that has been now slowly, in a phased manner, been rolled out across the country. It essentially collects all of the information about the services that a woman would have received when they go to a public provider, and each visit that they make is recorded on a physical card that each woman receives, which is called the MCT card. and they physically record these so that the woman is able to keep track of the visits that they need to make, and the health provider is able to as well. So that is the primary function of it, and in that sense it's been highly lauded. It's been successful in being able to track those services and being able to send reminders. So ASHA workers, who are the on ground health workers, are able to use the system to be able to physically map out the services and send reminders. In some cases, by physically visiting the patient, they're able to send remind them of the services that they are able to um, avail of, and that includes both antenatal and postnatal services during a pregnancy. But this has in a phased manner since 2011 been linked with the Aadhaar as well, and all of this information is then being linked to a central repository, which is being handled by the Unique Identification Authority of India, the UIDAI. And this then there's a sort of 360-degree surveillance model where um, the government has stated that they want information from birth to death about each citizen or resident that they are who has an Aadhaar card. And so there are several issues that come up around privacy and surveillance, as well as around data leaks and the security of these programs as well.
Could you briefly describe also the apps that you mentioned, Dr. Insta, for example, and the others that you outlined in your research?
Sure. So Dr. Insta was started by, the interesting thing about these apps and the actors behind them is that they're not necessarily governmental actors, they're not necessarily private facilities, and they're not necessarily non-governmental actors, they're individuals. And so Dr. Insta was individuals from India itself and the Indian diaspora. So Dr. Insta was created by someone who was living in America and was actually a bank executive and an entrepreneur who worked with a lot of entrepreneurial innovation kind of foundations in California. And he, in 2015, moved back to India and decided to invest a lot of his savings in what is called Dr. Insta, which is essentially a telemedicine service that is supposed to be targeted towards busy individuals who want to maintain a busy schedule and also be able to seek out health services. And so what happens is patients and doctors register for this service. It's an app, and you can essentially get doctor consultations on the go. And Dr. Insta is funded because of this businessman's experience. It's funded a lot by angel investors and venture capitalists in India and in the US. And he partnered with a doctor in India itself to kind of create the service and start the consultations and get a team of doctors to be behind it. So that's Dr. Insta. And Practo is another app that was created by two engineering students in their last year and who lived in Bangalore. And it was created because one of them kind of wanted to get second opinions on his father's health issues, and also wanted to evaluate the quality of the health practitioner that he was in contact with to kind of ensure that his father was getting the best care possible. So he, along with his classmate, decided to create Practo, which is an app that allows people to review and rate doctors and allows people to get second opinions if they wish to do that. Except a lot of the revenue that they get from this app is it comes from doctors themselves who maybe want to have a higher rating. And so the way that the business model works kind of boosts doctors' ratings without them actually being reviewed by patients. And in order for them to be sustainable from a business perspective, they aren't necessarily meeting their initial objective. And so in that sense, it doesn't necessarily it's not necessarily linked to reproductive health exactly, but it creates a system where doctors are kind of allowed to continue not necessarily providing the best care, providing complete information, and still being rated well or reviewed well based on the business model that this app runs on.
So the next thing I want to ask was around the approval process of obtaining an abortion. And I guess based on what you said earlier about contraception as well, if you're under 18, and what the effect of that approval process has had on pregnant people. From your research, I understood that there is a need to have like a guardian approval of access to abortion, and the government's involved as well. And so I was wondering if you could talk through what those approval processes are, and sort of the effect that would have on the person seeking the service.
So just to flag that that's not necessarily the case, that you would need to have a guardian or your husband or whoever it is, apart from the patient themselves, sort of sign off on the abortion. But it does end up being the case in certain for certain categories of women. So one vulnerable group that we highlighted already was unmarried women, and just because of the sort of infantilization of unmarried women, there has been again a sort of local requirement, local in the sense informal. It's not in the law, but there has been, I did find instances in Delhi, in major hospitals, of providers asking for consent of the partners as well. And in the case that the woman is not able to provide their Aadhaar card, for example, the Aadhaar card, they do need to have some identification. So they still, you can provide your husband's Aadhaar card, you can provide your guardian or your parents' Aadhaar card as well. And this then again becomes a source of concern for unmarried women if they are not able to disclose at home, for example, that they are seeking an abortion and do not have an Aadhaar card. Then they will essentially not be able to get an abortion at a public provider. And this is also the case with benefits. So in the case of accessing benefits, it's a more sort of formal process. So you do have to give the details for both husband and wife. So you can see there that all of these benefits are not only targeted towards on the narrowly defined scope of mothers within reproductive health, but also in a heteropatriarchal family setup. So you need to have a husband, and you're only able to you need to have the husband's consent, you need to have their details, they need to have another Aadhaar card. So the entire the husband and wife need to provide both the set of details. And you can only avail of benefits for up to 2 children. So that's the sort of family planning approach that's being taken through exclusion as well.
So could you talk about sort of foreign organizations that have a presence in India that work on sexual and reproductive health care, and what they're working on at the moment in the country?
Sure. So there's a lot of foreign organizations operating in India because, like we mentioned before, this kind of reproductive health care provision is a big international development narrative. So some of the organizations that we've talked about include the United Population Fund, Life Matters Worldwide, the Bill and Melinda Gates Foundation, BBC Media Action, the World Bank, and USAID, which is the United States Agency for International Development. And it's not that these organizations necessarily have an explicit, or not all of these organizations have an explicit anti-reproductive presence, but they leave out a lot of aspects of reproductive health care, which enable their presence to act in some sort of anti-reproductive kind of rights and autonomy fashion. So the one that is really explicitly kind of anti-abortion, anti-contraceptive is Life Betters Worldwide. And unlike the rest of these foundations, it's not a big foundation. It's not funded by a lot of money. It relies on donations, individual donations. And it's a religious-based organization that started in Michigan in the US. And it has a lot of partners worldwide. And really their goal is to educate based on their interpretation of the Christian faith and what it is that they want to kind of convey in terms of abortions and contraceptions and the like. So they operate through their missions, through churches, through local churches, and through pregnancy centers. And so they partner with local hospitals and local churches and prayer groups, and they don't directly provide any services, or they can't actively stop any services from being delivered, but the way they choose to operate is to educate and to inform in whatever they understand to be educating and informing, and they work with local hospitals to gather groups and kind of relay their message. So that's kind of the one organization that has an explicit anti-reproductive presence and is unlike the rest in terms of its size and their objectives. The United Population Fund is associated with the UN, and it defines itself as an organization that ensures that every pregnancy is wanted and every childbirth is safe and every young person's potential is fulfilled. And so they have kind of an emphasis on family planning, which is really the narrative of reproductive health in India in general. And so they advocate for the inclusion of reproductive rights for adolescents and different national strategies that kind of take maternal, child, and adolescent health into account. And they advocate a lot against child marriage and dowry violence. And they promote adolescent reproductive health, but again, it does not necessarily address the totality of reproductive health, and everything that they do is really focused more on maternal and child health, and kind of protecting adolescents from getting married too early. And the Bill and Melinda Gates, BBC Media Action, World Bank, all these organizations also have very similar kind of programs and initiatives where they focus on family planning and on one end, and then they focus on maternal and child health on the other. That's kind of a two-pronged approach for many of these organizations, and especially for Bill and Melinda Gates and BBC Media Action, they focus a lot on technological solutions and technological initiatives. So there's for example, BBC Media Action, in partnership with the Ministry of Health and Family Welfare in India, created an app called Kill Curry, which was directed towards rural women to kind of relay information about fertility and pregnancy and anti and postnatal care for up to 2 years to women, so that they can monitor their health and their child's health. But again, a lot of these initiatives and a lot of these organizations really work towards pregnancy, towards reproductive health that's centered around pregnancy and towards centered around maternity, less so around kind of spreading awareness and information around all the other services that women have access to and women have a right to. And that's especially the case with USAID. And I mean, especially with USAID, that's really kind of caught up in the geopolitics of relationships, the geopolitics of kind of the tensions that are going on in the US, and that's translated to the services and the kind of development initiatives that they have in India and worldwide. And the best example of that is the Gag Rule, which states that, has been enacted by multiple administrations and has been enacted by the Trump administration again, And really, it's just a rule that kind of states if organizations that do have USAID funding provide services or provide information about services or abortion services, that they will not be eligible for USAID funding anymore. And so they're actively working to restrict services to abortion and kind of do not allow for their organizations to provide the totality of services and information that they could provide. And so again, that's creating a gap from an international perspective domestically that is weighing down on the barriers that women already face and is bringing reproductive health, as it has always been brought into like these patriarchal systems that kind of continue to limit access to women, and especially women who would be stigmatized for accessing these services in the first place.
Thank you so much. I just wanted to ask if there's anything else you wanted to add about work that you're doing at the moment that's related to this, or anything that's coming up in the country that's you wanted to mention. If there's anything else.
Yeah, I think with regards to both of those questions of where is the country headed and our the work that we are trying to develop as well is really focused around public health emergencies and the sort of access to contraceptions, abortion, and the right to privacy in those contexts as well. And there have already been organizations, so Hidden Pockets I mentioned is one that's doing advocacy and is trying to build community driven initiatives around ensuring that there is information at least about contraception and abortion in different parts of the country, but these will necessarily become issues where women are not able to access these services, or are not able to travel to areas that are able to provide these. And that's not just the case with abortion in particular, but also say with HIV and the ART sort of treatment that happens with HIV. That's been that there have been several initiatives that are trying to deal with that as well, because people are not able to access these treatments and these long-term treatments anymore. So I think that's the sort of direction that work at CIS is also going to be taking.
Okay, well, thank you guys so much for your time. It was great to hear about the research you've done and great to speak with you.
Thank you. You too.
Likewise. Thank you so much.